I want to welcome everyone who's joined. We're going to give it another minute or two just to let some others join, and then we'll get started. So on behalf of the Children's Research Board, I want to welcome you to our second of 3 Research in Focus conversations. My name is Kathy Graham, and I serve on the Children's Research Board, and I'm lucky enough to head up the board's education committee. Today's topic is asthma management, empowering students and families to improve outcomes. The third and final call will be on November 19th at noon, and we will examine adverse childhood experiences featuring Dr. Nia Hurd-Garris. This session will explore how adverse childhood experiences such as gun violence and divorce impact the long-term health of kids. I want to thank you to all of the 2020 education champions who are listed on this page. Their donations go a long way to furthering research and education, which is really key for us. I want to touch on a few housekeeping items. If any of the participants need to adjust the view of the PowerPoint slide, you can click on View Options at the top of your screen, then click Fit to Screen, which should adjust to show the full slide. I also want to remind all the attendees that your microphones are muted and your cameras are on. And we really welcome you to submit questions in the chat or to even use the raise the hand function to ask questions any point during the presentation. And also in the event I missed the question, and in the event there's some at the end of the presentation, we will have an interactive Q&A for the last 10 or 15 minutes. So it is my great pleasure to introduce Dr. Ruchi Gupta, a great friend to the Children's Research Board. Some of you may have participated in a wonderful event last year where Ruchi, back when we all could meet in person, got together with us to discuss her work and her many awesome insights. She's a professor of pediatrics and medicine at Northwestern University Feinberg School of Medicine, and is also a clinical attending at the Anne and Robert H. Lurie Children's Hospital in Chicago. She has more than 15 years of experience as a board certified pediatrician and health researcher, and currently serves as the director of the Center for Food Allergy and Asthma Research, where she's actively involved in clinical and community-based research. Dr. Gupta is nationally recognized for her groundbreaking research in areas of food allergy and asthma epidemiology. That's a tough word. I looked it up. It means the branch of medicine that deals with the incidence, distribution, and possible control of a disease. So everything that relates to the disease. Specifically, her research has been in childhood food allergy prevalence in the United States. She has also significantly contributed to academic research surrounding the economic impact of food allergy, pediatric management of both food and allergy, as well as asthma, improving the quality of life and children, the quality of life of children and caregivers, and implementing community intervention in schools for students with food allergies, asthma, and other health conditions. Dr. Gupta is the author of Food Allergy Experience, has written and co-authored over 100 peer-reviewed research manuscripts, and has had her work featured on major TV networks and in print media. So I'm going to turn it over to Ruchi to take control.
Thank you so much for that excellent introduction. And yeah, epidemiology is a bit of a tough
Did I
word.
pronounce it right? I even worked on,
That was incredible.
genetics.
No, that was really nice. And thank you and welcome to everyone for participating. I know it's not quite the same as when we got to spend time together in a room, but I want it to be just as interactive. So please do, feel free to ask questions and engage in a conversation. And if anything that I talk about is particularly interesting to you, please feel free to reach out to me. So yes, last year I gave a series of talks on food allergies, and today I'm going to talk to you a little bit about the work we're doing and others in the area of asthma. Okay, let's see if I can properly do this. Yep. Oh, whoops. Okay. We're all learning. All right, here we go. So here. All right, so I'm going to start with talking to you about a couple studies we've done around asthma management and empowering students and families to improve outcomes. And, this is a core part of our center. One of our biggest things is how do we improve management of various conditions? And the number one way is to empower families, to empower children and their parents. So we do a lot around trying to engage them as being their own champions and us not just talking to them. So I'm going to talk to you about a couple studies that really use this method. And so this is the first one. So the objectives, well, actually, these are the overall objectives. So we're going to talk about a couple of studies. One, the prevalence of pediatric asthma in Chicago by neighborhood, the school programs that I was talking about to create and empower students, to understand community factors that impact their asthma, and to help determine ways to spread awareness. And then we're going to talk about a study we just completed, the Itex Study, which utilizes sensor technology to monitor inhaler use by families and physicians to improve asthma management. Okay, asthma in Chicago. So this is a story. I like to tell it in story. So here's my story. So 16 years ago, I came to Chicago from Boston, really to study asthma and how can we improve management and asthma disparities. And I came here because there was a leading international leader in asthma research in Chicago who soon left me. But I wanted to really learn from him, and he had some pretty large studies in the Chicago area. So I came here 16 years ago to start this adventure and started analyzing some of the data that they were collecting across Chicago. And so this is a study, this is some background first. So more than 9 million children in the US are affected by asthma. We know that disparities are on the rise, and asthma rates, morbidity, mortality are all disproportionately higher among Black versus white children. And we all know that an urban environment like Chicago is often implicated. So little attention is paid to contributions at the community level and within the inner city, because usually we talk about like numbers, like 9 million children in the US or how many in Chicago, but we really don't break it down by where you live. So the rates in Chicago specifically are very interesting because Chicago asthma prevalence is higher than the national asthma prevalence, about 13.9% in Chicago. So decent amount higher. And what we found was geographic variability, that asthma prevalence varies within and between Chicago neighborhoods. And I'm going to show you these maps. Then what we sought out to do was look at positive and negative factors. So what factors could be associated with these differences and this variability we saw in neighborhoods. This is some of the additional stuff we found from this study of Chicago children. And just to let you know, this was of children through Chicago public schools and Chicago parochial schools, surveyed, just across all neighborhoods of Chicago to really better understand asthma rates in children. And this is older. Let me see if I can read that really small. I'm trying to remember, 2006. So this is a long time ago. But even back then, we found that the average asthma rate in Chicago was about 14%. And now you can see that difference, 12% for white children, 12% for Hispanic children, 20% for Black children. And then what was super interesting is that we found that it really varied by the neighborhood you lived in. So predominantly Black neighborhoods had a range of asthma. Some of those neighborhoods only had rates of 4%, while others had 44%. So just drastic differences. And then predominantly white neighborhoods also ranged from that's Hispanic neighborhoods 2% to 30%. And then Hispanic neighborhoods very similar from 0% to 29%. So very interesting. So it's not all race. There is, huge amounts of variability by the type of, or which neighborhood you are living in. Race did explain a significant proportion, but definitely not all the variation that we saw. Okay, so here you go. Here are our maps. So this is the geographic variability of asthma in Chicago. And it's so interesting because we published this so long ago, but it's still used to teach most public health classes across Chicago and talked about all the time. So one of the things we're in the process of doing right now is replicating this. So we're working with CPS again to try to develop new maps, just because we would like to get a new sense after 15 years of how this has changed. But as you can see here, the dark green are the lowest rates, and then the red are the highest rates. And even when you look at different areas like the north side of Chicago or the south side of Chicago, you do see, you see more darker colors in the south side, but you do see spots of green. And up in the north side, you do see orange, quite a bit of orange, and then yellow and green. So what was so interesting is you could be living in a neighborhood that's just right beside another neighborhood, and your rates could be drastically different. So this was a really exciting study for me. I did not expect to find it to be so variable. And then in the second one where we overlaid race, you can see how it still varies. And I know this is pretty small to look at on the screen, but I hope it gives you the basic idea. Okay, before I get off that study, I do, want to let you know. So when we did these maps, we got a lot of attention. We went on WGN, a Chicago Trib, and then NPR called, and this led to the next study. So this is the next part of the story. So this was really fun, crunching numbers. We do a lot of that epidemiology. And so when we did this, NPR called and said, "This is really interesting to me. Can you meet me in a neighborhood and let's talk about why we're seeing these rates?" And so they said, "How about meeting me out in Englewood, and can you find a family whose home we can go into to discuss why the rates are so different there than one of their neighboring neighborhoods?" Now, I was sitting in my office at Northwestern crunching, and Lurie Children's crunching these numbers, and had not really gone out to the neighborhood and done all this. So I found a family who lived there who said they would allow us in their home. And I met this NPR reporter in Englewood, and we walked around the neighborhood together talking about it. And we walked into her home, and we sat there for an hour discussing what are the reasons for this incredible difference that we see by neighborhood. That really honestly opened my eyes. I consider myself a community researcher, and I had not actually gone into the neighborhoods to really understand what was happening. So after that, our next mission was, we're not sitting in our offices in Streeterville. We are going to get out to the neighborhoods and find out what is causing these differences, because that could have a huge impact. So that led to the second phase of my asthma career, which was student empowerment. And so what we decided to do here is develop two programs. We started by calling it START, Student Asthma Research Team, and then we changed it a little bit and called it Student Media-Based Asthma Research Team. So these programs were implemented in 3 Chicago schools with high asthma rates and poor asthma morbidity during 2010-2011 school year. So pretty much after that was published, we got a grant to do this next study to empower students to improve their asthma self-management skills through photography. So they would photograph positive and negative factors that affect their asthma in their environment, in their community, and they created public service announcements for other students to increase asthma awareness and catalyze behavior change. So by spending time in that family's home in Englewood, what I learned is They know the answers. We don't. So we needed to get out to the schools where these kids are impacted and ask them, can you help us? You be the researchers. We'll give you the tools and you go out in your neighborhood and help us figure out why are we seeing higher rates in your neighborhood? What are positive influences? What are negative influences? And then you tell the story. I don't need to be telling the story for your neighborhood. You need to. So we had them create public service announcements for their communities from students in their communities. And I personally feel like this is the most effective way because they're going to stay in those neighborhoods even when we leave. And if we give them the tools to make positive change happen in their neighborhoods, then it will continue. So we got, in this first phase, we got 180 photographs and 112 journal entries. And we reviewed all of them to see what the major themes were. And so communities reported factors included things like social support, neighborhood environment, lifestyle, and then well-established asthma factors that we're familiar with, like smoking, et cetera. So here we go. So when we gave the students pre and post evaluations, this is what we were looking at. So their knowledge, their pediatric asthma quality of life questionnaires, their ACT, asthma control test. You can read them all, but we had them fill out a ton of stuff to really see if we were making an impact for them individually. And then for the caregivers, we also asked their parents or their caregivers to fill out a few surveys about their child. So our outcomes. So after surveying students and parents, following the program and viewing these public service announcements, there was an overall increase in their asthma knowledge, their self-efficacy and empowerment, their quality of life, and their emotional support. Student, peer, and parent asthma knowledge and caregiver-related quality of life. So it was very effective. Now, the hardest thing about these programs is they're very difficult to fund because these are not things that the NIH necessarily puts money into. So these were all small foundation grants, but I feel like they had some of the largest impacts. And here's a couple videos, and I'll just show you a little bit of them, just so you can see some of the things the kids created. Can you hear it? Are you getting sound or no? Oh, wait, 1 second. Let me press play. That would help. No?
Asthma.
Oh.
Did you know?
1 in 7 kids have asthma in Chicago.
1 in 4 kids have asthma in my neighborhood.
What is asthma?
Asthma is an inflammation of the lungs. Asthma can make it hard for me to breathe.
Asthma is the #1 reason for kids to miss school.
500,000 people are hospitalized for asthma every year.
Asthma costs $20 billion a year in the U.S.
Asthma can be controlled with medicine.
I can do anything anybody else can if I take care of my asthma.
I can do anything anyone else can do as long as I take care of my asthma.
I am asthma, asthma is me, and I'm not a disease.
For more information about asthma,
1 in 4 kids have.
Oh, no. Sorry, there we go. Okay, there's one. Here's another one from a predominantly Latinx neighborhood.
Asma es algo muy serio. Casi 1 de 3 niños en mi comunidad tienen asma.
9 personas mueren por asma cada día.
Era como un elefante pisando en mi pecho.
Se sentía como si mi garganta se cerraba.
Asma es una enfermedad de los pulmones. No lo puedes agarrar de otra persona.
Para gente con asma, es importante evitar los disparadores de asma y educar a los otros acerca de cómo se puede ayudar.
Algunos disparadores.
Polvo. Deje de fumar acerca de los niños.
Inhalación de los disparadores de asma conduce a la inflamación de los pulmones. El endurecimiento.
I want to just give you a couple quick examples. I'm not going to play them all, but these are all available on our website, and there's plenty more. So please feel free to visit. We wanted them all to be short, so you can see they're all somewhere, under 2 minutes. so that their schools and students and neighborhoods could be able to watch them and in any format at any time. So here's a little bit of another one.
Bro, that was intense. Can't believe we played all the way through lunch.
Yeah, no, I haven't ran that much this last season.
Yeah, same. Wait, by the way, do you know what class we have next?
It's A period, so Spanish. And it started like 5 minutes ago, so we better hurry.
All right, cool.
Bro, look. Isabel looks like she's struggling with something. Maybe she's tired.
Oh, I don't think so. No one saw her when they were running in for class. You gotta go help her. Are you okay?
What's wrong?
I feel tightness in my chest and I can't breathe very well. I can't stop coughing.
What are you doing?
I was playing soccer outside.
Oh, shoot. We forgot to ask for lockers.
This is a...
Doesn't matter. We don't have any time.
We're fine.
Okay. It's a video of kids trying to help their classmate, basically, with asthma and learning about it along the way. And then I'll quickly, for the sake of time, just briefly show you one more in this group.
Many kids in our community have asthma. There are different factors that can affect someone's asthma, and if exposed to certain triggers, kids can have serious asthma attacks. Let's go inside Jared's body to see what happens when he is exposed to some of his worst triggers.
As you can see, the body responds to things like smoke, dust mites, mold, strong scents, and other asthma triggers. The airways constrict and become irritated from the triggers. The only thing that can help now is inhale.
Okay, all right, you get the gist of these, huh? So what's so exciting is watching these students develop and create their scripts and their videos, and then watching how empowered they felt when their classmates and their teachers and their families would watch these and start asking questions around it. So it was a very positive feeling for them, and really taught them the skills to truly become a leader in their community. Okay, now let's see if this works. Okay. So it's a little delay and I'm a little trigger happy. I see. Okay, lessons learned. So these programs were able to engage adolescents, like we talked about, and improve their asthma self-management and the community's knowledge and support of asthma. Through these collaborations, they were able to gain better understanding of the socio-environmental determinants of asthma, their own personal ones, and for others in their community, asthma morbidity within a unique community, and students felt empowered to make a change. So what did we do after this? We took these curriculums and we expanded it beyond an asthma focus, because one of the things we found is when we went into these schools, we would pull out students with asthma, and other students wanted to really learn about asthma and other conditions too. So how do you make this sustainable, really? And so what we found was that if we could take a classroom and give a curriculum to a teacher and just give them the base of the curriculum and divide up students into whatever health conditions they were interested in, and put them into working groups, and then follow the curriculum to be able to develop PSAs and understand, facilitators, positive and negative things that may impact any condition, any disease, but have students work together in those groups to come up with solutions, to develop PSAs, to develop interventions. So we created a whole curriculum around this, and we put it on a thumb drive and we circulated it to schools. We definitely did through Chicago Public Schools, and then we still have it available for any schools that would want to give this to their teachers. So please, if you have a school that might be interested, please reach out to us. We think it's a great curriculum, and I think it is very amenable to virtual learning as well. All right. One step further to this is something we did just recently last year and this year, and this was the CPS Northwestern Student Health Leaders Program. And what this was a program where we brought 95 high school CPS students together from 16 different schools across Chicago who shared a passion to become a change maker in their communities. And there were 4 half-day workshops, and they were pretty incredible. They came in on Saturdays for half a day. These 4 big pieces were part of it: vision, teamwork, realization, and presentation. So each workshop was half about empowering them as individuals and then empowering them to make change happen around a health condition in their neighborhood. So they identified personal goals and discussed health issues in various communities within Chicago. Teamwork, they worked in groups, learned the principles of design innovation in order to develop an intervention for a health issue. Realization, they toured the medical school and learned from physicians at both Lurie Children's and Northwestern and medical students about their experiences. And then presentation, they presented their interventions for health issues and explained how they were going to be implemented. So they all developed public service announcements because we find videos very effective. And then they all came up with their own intervention that they would want to do in their community to improve a condition. And we are hoping to continue this. We're actually working with the design school to make it more of a intervention in a box that we can spread across the country because we felt like it was so effective. These are the topics that they picked, and they picked these. So although, multiple things like food allergy, I was hoping someone would pick up, but they didn't. They did pick up asthma, ADHD, depression, eating disorders, gender identity, violence, substance use, suicide, self-harm, obesity, nutrition, physical activity, sleep, and sexual health. So this is what's on the minds of our high school students across Chicago. They were very passionate about these issues, and I'm just this is the asthma group, since this talk is around asthma. Show you just a tiny bit of what they created.
You're probably wondering how I got here.
Oh, hey, are you okay?
Yeah, I'm just having a hard time breathing.
Do you have asthma?
Yeah, but it's not that bad.
Let me get you seat. It's very important that you take care of yourself, okay? Stay calm, take a deep breath. I'll go get your inhaler.
Okay.
Oh, hey, are you okay?
Pause it because we have a lot to go through. But if you, again, this is the website, you can see the videos they've created on any of these topics at that website, including asthma. And the kids filmed it, the kids wrote the script, they storyboarded, we taught them all of that. These are the health leaders, and this is them with their vision boards. We had them all create a vision board at the first one. And so again, student health leaders in collaboration with Lurie, Northwestern, and Chicago Public Schools. Okay. Next, we're going to talk about family.
I'm Ruchi Gupta. I'm a pediatrician. Asthma is one of the most common conditions in children. In the United States, it impacts about 10% of children. In Chicago, it's even more. It's closer to 14% of children. Hi. Hey, Brandon. How are you? Good to see you. Okay, now I want you to take a deep breath. Ready? What happens for kids with asthma is they usually have an inhaler that controls their asthma. It's a steroid. They take it every day. Then there's another inhaler that they're given. That is their rescue inhaler. And that helps them, if they're having trouble breathing, immediately to help them feel better. It's very confusing to families which one's which and what they're supposed to do with them. Pediatricians, or as physicians, we are unable to really monitor what they're doing. But it's a significant problem. It's one of the most common reasons kids end up in the emergency room and hospitalized.
Okay, sorry about that. I know I'm not this whole system is a little bit.
I'm Ruchi Gupta.
No.
I'm a pediatrician. Asthma is one.
Okay, here we go. So what is the study that I'm talking about? It is the Itex Study, Improving Technology-Assisted Recording of Asthma Control in Children. And the objective of this study was to improve overall asthma control and management among children 4 to 17 years with moderate to severe asthma. So, we talked about student empowerment, but, you can only go so far without proper management. And we are so fortunate to have amazing medications for asthma. And the biggest issue we see around it is actually kids taking their medication, especially their controller medication, because it's something that they need to take every day to control their asthma. However, if they're feeling good or they forget, oftentimes they're not taking that medication. And if they don't take it over time, that's when you start seeing them having more exacerbations. So how do you help kids and families, manage and take the right inhaler at the right time when they need it? And how do we as physicians help them do that and be able to monitor it? Because right now, if any of you have asthma or kids with asthma or people with asthma, you go to the doctor and they say, oh, have you been taking your inhaler? How often have you taken do you take your controller inhaler every day? And then they'll say, have you used your albuterol inhaler, your rescue inhaler, and how often? So what are we going off of? We're just going off of the report and what, the parent remembers. And oftentimes, they want to please their pediatrician. So they'll tell you, yeah, we take the controller every day and it's all good. But that may not truly be the case. And so how do we improve this whole system? So what we did is this was like I said, a sensor that I'll tell you more about. But we enrolled 252 patients with asthma, and we randomized them to test the effectiveness of the sensor technology on improving asthma control and related health outcomes. So the sensor, let me see if I can get to the next slide. Oh, I'll tell you 5 clinics in Chicago. So we did it through Lurie's pulmonary division. We did it at Lurie's Uptown Clinic and the Academic General Peds Clinic and Clark and Deming. And then we had 2 private practice because we did want to see how it worked in other settings. So we had a private practice pediatric clinic, Children's Healthcare Associates participate, and we had a private practice allergy clinic participate, Chicago Family Asthma and Allergy. So this is the sensor intervention. So this monitors the use of inhaled medication, both the, oh, sorry. Lori? Okay, I'll keep going, but if there's a question or anything, please do speak up. So it monitors both of these 2 types. So the controller and the rescue inhaler, there's a different sensor for each of them. And then the sensor is placed on the inhaler and the data is transmitted via Bluetooth to the smartphone. And then that data is actually transmitted to your physician's office. So one of those 5 physician's offices where you've been seen, they would get this data in clinic as well. Okay, so participating physicians, like I said, were notified by web portal to reach out. So this is what all the clinics agreed to this. They wanted to be extra notified if a patient missed at least 4 days in a row of taking their controller medication, or if they took their rescue medication more than 4 times in one day, because that would indicate they were having, trouble breathing and a potential exacerbation. So if either of those things happen, we would send a special alert to their physician's office, and then they would call the patient and make sure everything was going okay or if they needed anything. So through this platform, participants were able to track overall asthma management, better understand and monitor their asthma triggers, and provide important information with their healthcare team. So both groups, we followed them for 1 year. They also completed surveys at 1, 3, 6, 9, and 12 months. the ACT, the asthma control test, the parent self-efficacy, and the parent asthma-related quality of life. So here you see, whoops. So the primary and secondary aims. I know we're running late. I want to take your questions, but I just want to show you some of the results. What we found after 1 year was that ACT scores, which is asthma control. So how well controlled is that child's asthma? The asthma control scores increased dramatically. So the blue line is the control group, the black line is the intervention group, and you can see how significant that remained over a 1 year period of time. This is asthma quality of life scores. And as you can see, it shot up in that first month that they had the sensors, and then it kind of became a bit steady, but it ended up being significantly higher by the end of the study. Finally, what was super interesting, I want to show you, which was difficult for us to see, is that it did not reduce ED visits and hospitalizations. In fact, ED visits and hospitalizations actually went up in the intervention group. Oops. Went up in the intervention group. And why? Why are people with sensors having more ED visits and hospitalizations in that first year? And one of the reasons we thought this was the case is because they became more aware, more educated, and they had more contact with their clinician, right? So if their doctor's office is calling and saying, hey, are you having trouble? And they're like, well, I'm not sure. And, they have a conversation, they may encourage them to be seen in the emergency room. And that's a good thing for these families. So increasing, of course we want to decrease ED visits and hospitalizations, but I feel like if we would have followed them out longer, we may have seen that happen. But initially we saw this increase probably because our hypothesis is probably because of their increased awareness. Okay, and that's pretty much what I said here. So our findings suggest that this sensor-based inhaler monitoring intervention can improve asthma control and quality of life over a 12-month period among a diverse sample of children with moderate to severe persistent asthma. And although healthcare utilization was not reduced with this short time frame, additional study modifications along with longer follow-up may actually help me.
I hope that mothers and children that suffer from asthma, I hope they can get a hold of this tool to kind of get some extra help.
Yes, I feel amazing. Amazing. I'm just happy that I can do a lot more than I could.
I'm happy that she's happy, and as a parent, I can breathe because she can breathe.
And that was a video that UHG wanted to make about the study. So that study was actually funded by the United Health Group, which, as you know, is part of the insurance company, United. And what was really cool about that is they wanted to fund this because if we found it to be successful, they would potentially offer it to people who subscribe to their insurance. And we need to work with insurance companies and others to find ways to improve care. That we can, what's exciting is if we find something, then someone will pay for it to actually happen. Because a lot of times we find things, but then we can't sustain them due to funding. So that was an exciting part of this project, is to be able to work. It was the first time I had work with a group where we had common goals. They wanted to save money by keeping kids out of the hospital and ED visits, and we just wanted to keep kids out of the ED and keep them, from getting hospitalized and help them improve their management. So that was a really unique experience for us. That paper actually is accepted in pediatrics, and they chose it to be one of their featured papers. So they had us make a whole video around it to share. So we are really excited to share that, as we have to use technology in improving care in all conditions, but definitely in asthma. Finally, I am almost done. So this is my thank you slide. I really, really wish we were all in person and you could have interrupted me throughout this talk to ask me questions. I think the last time I did this with a group, we got through the first 4 slides because there was so much interest in questions. And I'm sorry, but I'm hoping we will be able to do that in the near future. But if you do want to get in touch and have a conversation, this is how you can find us at the Center for Food Allergy and Asthma Research, and me specifically. So my email, I'm happy to share as well. That's it. I'm ready for
Thank
questions.
you so much, Ruchi Gupta. You're wonderful. We appreciate your work and all your insights. And, you know, we have a number of people in the meeting today who likely have questions if they're bold enough to ask. And I would encourage you to put your question into the chat or just type into the chat that you have a question. Everybody's going to be off mute at this point, and we'll cover as many questions as we can in the next, let's call it 15 minutes that we have with Dr. Gupta. But I'll get us started with one. You know, it really relates, Ruchi, to your kind of first section that I found fascinating, where you talked about both the race and kind of neighborhood impact of asthma. And you did some great work after to support kids and to come up with a way to monitor usage of medicine that helps. But were you able to really find what caused the race disparity and the geography or neighborhood disparity? I think you're still on mute.
Sorry. Yeah, that's a great question. So we did publish a series of papers after that, which I did not get into. So I'm glad you asked about it. What are those neighborhood factors, right? Like, so I never answered that. What did they say and what did we find to be significant? And it was fascinating. Like some of it was not, you know, some of it is common, right? So neighborhoods with smoking and drugs, and a lot of people showed pictures of things like that. Obviously you're going to have higher rates, but one thing that was really interesting was violence. So police, gangs, all of that. If you lived in a neighborhood with higher violence, you had higher rates of asthma. And that, you know, that correlation, is it a, you know, we can't say it's a cause and effect, but we definitely saw that throughout. And, you know, we all know that stress is a major factor for asthma as well. And so that was a really interesting one. You know, one of the biggest ones that I think we could all totally understand was support, you know, so parental support, peer support, school support. The more support they had around their asthma, the less asthma you saw and the better outcomes overall. So that, you know, what did we do with the data we found? We were able to push more support. You know, we engaged all the caregivers, we engaged the schools all showed the PSAs. We're starting to do programs with CPS to be able to have, you know, now, you know, after that amazingly long strike, we do have now social workers, or they are going to be having nurses in every CPS school and social workers in every CPS school. So we've been working with CPS very closely to see how we can have some monitoring of kids with asthma and to support them more closely, especially in these high neighborhoods, high asthma neighborhoods. So there are things that did come out of this that I think we can pinpoint schools or areas or neighborhoods that need the most help and start doing interventions. And at least the Chicago Public School is very much on board with that.
Right. We have a question in the chat from Heidi, who, you know, is acknowledging that schools have Epipens, but do they have inhalers?
What a great question. That's absolutely right. And we are working on these policies right now. So I am so glad you asked that, Heidi. So yes, they do have epinephrine auto injectors now in schools, and that law passed, and there is a law in the books to have emergency inhalers in all the schools. And that will happen. The only issue with that right now is CPS being broke, is trying to figure out how to pay for it all. As you may know, the epinephrine auto injectors, some of the companies that make them, I think now at least two of the companies, both EpiPen and AviQ, have a program for schools where they will give schools free epinephrine auto injectors to use. However, that is not the case with inhalers, but inhalers are significantly cheaper. So CPS is working on how to get those, but it has passed, and they can have emergency inhalers, and there is a big push to make that happen in every school. So really great question.
And we have another one from Phoebe. Children with asthma more at risk for having worse COVID symptoms if they are exposed?
Great question. We actually just did a whole talk on allergies and COVID, and it's fascinating because there was so much fear around this because it's respiratory and COVID is, and what's what's going to happen. And what we've seen is no, they don't have an increased risk for developing COVID or for having more severe symptoms. We haven't seen that in the data that's come out across the country. And that's very, very positive, because it did cause a lot of fear amongst families with kids with asthma. So what we are seeing, honestly, there is some research about kids with allergic conditions, including asthma and food allergies, eczema, the whole, atopic spectrum. They may actually be slightly protected from COVID because of the immune track that their bodies go on. They kind of go down this T2 path instead of this T1 path, and I won't get into all of that, but basically there is some speculation that they may potentially be protected, but we don't know that for sure. But what we do know is they are not having worse symptoms or at higher risk. And one of the really, I guess, we got to take out whatever positives we can from COVID. One of the things we're seeing is kids with asthma, this is the season right now for exacerbations, and we're not seeing as many. And a couple of reasons for that is that most people are wearing masks. And in schools, if you go to schools, you typically have to wear a mask. So they're not spreading germs because typically viruses are one of the biggest reasons, to have a secondary virus for, like you said in your question, for those exacerbations. So they're not exchanging normal cold viruses as often right now. Many of them aren't in school. And then also, they're not going to school. So they're not going out of the house as much and being exposed to environmental triggers. So we are actually seeing less asthma exacerbations during our peak season right now. Okay, another question. How does violence serve as a factor in asthma? That's a really good question. And we were really curious about that as well. And we do think it's from the additional stress and anxiety. And so as we know, stress and anxiety, can influence pretty much any health condition, and definitely asthma. So there are two types of stress, kind of your daily stressors, which typically don't influence disease, which is, I was late for this meeting, or I couldn't get into the Zoom call, so I got a little stressed out, or, things like that, like things that we deal with on a regular basis. But then there's big stressors, and those are things like regular violence in your neighborhood, or that fear, or that regular anxiety that definitely have an influence on your health. And that has been shown to be a major factor in increasing exacerbations for asthma. So, your question, is it chicken and egg? Does violence cause asthma? Probably not, but it does increase asthma exacerbations for sure.
Another one here from my end, since we don't have any in the chat, but thanks for everyone who asked questions.
Yeah.
There are many of us here today that are really focused on childhood mental illness or mental health. And according to the Centers for Disease Control and Prevention, anxiety and depression are more common among children with asthma. Can you share your thoughts on the role of mental health in treating young children with asthma?
Oh, absolutely. I mean, I am with you 100%. Mental health is so important. And these days during COVID, even more. I mean, I heard a statistic that between 11 and 17, 50% of children are having some signs and symptoms of anxiety or depression. And that is just not acceptable. What is happening right now in our world and how it's impacting our children is something we really have to deal with. And yes, kids with asthma have higher rates because it limits your lifestyle. One, there's bullying. Two, what can you do and can't you do? And they're not often encouraged to play sports or run around or do things that other kids do. And that's something we're really working on trying to change, because again, as I said, we have such great medications for asthma now. It's really come a long way, and every child should know. And that's why I love what those kids said in that first video, I am not my asthma, right? So we're not defining these kids as asthmatics. They are just children who happen to also have asthma, and that asthma can be very well controlled. And we need to make sure we're able to do that and get kids the care they need so that they can do anything and really feel, fully whole. So That's a really good question. I mean, we're tackling mental health, even though we're the Center for Food Allergy and Asthma Research. We're working with Lurie Children's very closely right now to develop a mental health initiative. It's an online system to help. It started out with staff and physicians at the hospital, but we're moving it into the community. So it's an online system where you take a survey and you pick your areas of need, and then it kind of takes you into resources for the different things. And those could be, online resources, they could be group classes, or they could be individual sessions. And so Lurie has been promoting so many amazing initiatives, and we just had a meeting with some leaders of many of them around mental health as we try to roll this out. And we would love it not only to be for, obviously, Lurie patients and families and staff, but roll it out into the community. And one of our first partners is always the Chicago Public Schools, because those families and kids could definitely utilize it. So yes, 100% with you. I think it is where we need to spend the majority of our time right now, really tackling mental health issues, especially today.
And Ruchi, I think we have probably a number of parents who have children with asthma. How can they best support not only, helping address the asthma, but also the mental health issues?
So the asthma, absolutely. I think right now, I think it's very important that and your child knows that they are not at higher risk right now, and they're okay. And maybe the stuff around, there's less exacerbations now, and hopefully they feel safer, because if they are going to school, kids are wearing masks and they're not as exposed and they're keeping distance. So, and those are all, like I said, the positive aspect of this right now. The mental health issues they may be facing are very probably in line with everything that's happening. If they're remote learning, or if they are going to school in some capacity, but it's not quite the same, if they're not able to see their friends or socialize in the same way. There are so many things. And, personally, I have 2 kids. One's supposed to be in college, but, they closed the dorm. So, he's having to do his first semester at home. And I have a freshman in high school at a brand new high school. And, she doesn't know anyone in the school, and she can't meet them really, so I'm with you 100%. And I think the biggest thing we can do is support our kids, listen to them, support them, try to do things that are safe, that they enjoy, try to, have them meet up with people, with distance, et cetera, all the safety precautions we can do, and make sure they know that this is not permanent, right? Like, we have to take it day by day and enjoy every day, like as much as we possibly can, but know that, it will end. Like that I can guarantee, like we will go back to normal. And everybody is working for them. I have calls with CPS pretty much weekly to try to see when they can open safely and how they can open safely. So there are a ton of super brilliant people working to make this, back to normal, especially for our kids, as quickly as we possibly can. So I don't know if that helped at all. Obviously I'm not a mental health expert, but I'm in it with you and doing the best I can. And I'm sure you are too, but we do, we just, in our center, we hired a clinical psychologist, a pediatric clinical psychologist. So that's why we're getting into more mental health work. So if there are questions, and, of course, Lurie has amazing resources, but if there are specific questions around mental health, I'm happy to help guide you into the right direction or connect you with our clinical psychologist as well.
Great, thank you so much. And a final question here really relates to eye track.
Yeah.
If I understand your remarks correctly, the sensor was used in the study, is currently being used for different purpose, tracking medication use. And clearly the data indicates that adding the sensor-based monitoring does present a case for improved asthma control.
Yeah.
I'm interested to understand kind of what your next steps are. You've tested a small group, kind of where is this going to next?
I know. I keep trying to decide that too. So, tell me your thoughts. So the sensor is available Now it's about how do we get it to families, right? Like, so that's great if United does it, but that's one insurance company. So how do we get these techniques covered so that they can get into the hands of families? I did want to continue that research, but we didn't get funding to do it, to continue to follow these kids out another couple of years, just keep them in a registry and see what happens over time, and continue to think about how to improve it. So I would love to continue or do another study where we make changes, because you always learn from the first time you do it, and try to see. We have a couple ideas of how this could work better for patients, but I think the biggest thing is having some kind of technology that connects the patient. The biggest things we heard from the families were they loved their knowing that their doctor knew, right? They loved that their doctor got this data, and when they got a call from their doctor, they were really happy, right? They felt really good about that, because that doesn't usually happen. So somebody's watching over your child, your clinical care group is in it with you. So I think using technology in that way, which is starting to happen. Everything is slower than we would want it to be, but I do think it's moving in that direction. And we are applying for some grants to continue work in this space. So hopefully, we'll have study number 2 in this in the near future.
I hope so too. And maybe the Children's Research Board needs to think about that.
Yeah. Oh, that would be great. I would really appreciate it. And yeah, I think we're on to something here that could really help families and kids.
Well, thank you for all your great work. I'm going to turn it over to Christy, our fearless leader, to close.
Thank you, Kathy, and thank you again, Ruchi. I've already extended my personal gratitude for you carving your time out of your day to join us. This is, I think, a really great surrogate for that moment that we shared last year, all gathered around that small table in a conference room. Yep. I was so happy to hear so many people that had questions for you. And again, thank you for making the time to help us inform people around us and our board. It's incredibly helpful. If we can, I'd like to again recognize the individuals and companies that allow this platform to exist and allow us to amplify the remarkable work that's taking place at the Stanley Manne Children's Research Institute, at Lurie Children's Hospital, and out in the community through the Patrick M. Magoon Institute for Healthy Communities. Without this support, our ability to have impact in our community would be much more limited. And with that, I'll just end with a brief reminder for our next session taking place on November 19th. We are thrilled to have Dr. Nia Hurd-Garris join us for a conversation around adverse childhood experiences. And when I first heard about this topic, I immediately went to the notion of gun violence in our community. But her work focuses on such a broad spectrum of adverse childhood experiences that include something that is, significantly prevalent throughout every community in Chicago, and that's divorce. So I would encourage you to stay tuned and to join us on the 19th if your schedule permits. And if you want to scan that code, it's a quick and easy way to RSVP to that event. And then finally, I just leave you with an expression of gratitude for so many of our board members who joined us today. And for those of you who are guests of our board members, I would encourage you to think further about considering to join us. We are a completely volunteer organization, and while we work to raise funds to support innovative medical research, we also serve as important champions and advocates within our communities, amplifying the message of the remarkable work that's taking place in the institution. We serve as great mentors to postdoctoral students, and we provide this great connection and access point to hear from experts such as Ruchi. So thank you once again for joining us today, and we'll look forward to seeing you again in November. Be well.